Good afternoon, everyone. I'm Melissa Hansen, and on behalf of the National Conference of State Legislatures, I would like to welcome all of you to today's webinar, The Social Determinants of Health, Reforming the Healthcare System to Work Smarter, Not Harder, to Eliminate Health Disparities. Today's webinar is the first in a two-part series on health disparities. The second webinar, Health Insurance Exchanges and the Potential Impact on the Uninsured Minority Populations, will be held on August 23rd at 2 p.m. Eastern. These webinars are part of NCSL's Health Disparity Project. In its third and final year, this project has created many evidence-based resources for legislators and legislative staff as part of the National Partnership for Action. These resources, created with the guidance of our advisory group, can be found on the webpage on your screen. We'd like to thank the Federal Office of Minority Health for their support of today's webinar. We are very fortunate to have two experts joining us on today's call, California Assemblymember Richard Pan and Massachusetts Representative Jeffrey Sanchez. Assemblymember Pan is here today to share his expertise as a pediatrician. Prior to his election, Dr. Pan served as the Associate Professor of Pediatrics at UC Davis, where he directed the UC Davis Pediatric Residency Program. There he developed a national award-winning program to promote healthy lifestyles by partnering with community groups. He also co-founded the Sacramento Health Improvement Project, which brings together doctors, hospitals, clinics, and community leaders to increase access to primary health care. Dr. Pan earned his bachelor's degree from Johns Hopkins University, his medical doctorate from the University of Pittsburgh, and his master's of public health degree from Harvard University. Chairman Jeffrey Sanchez serves as Massachusetts State Representative for the 15th District. Chairman Sanchez was appointed House Chairman of the Joint Committee on Public Health in 2009. Prior to his appointment to the Committee on Public Health, Chairman Sanchez served as Vice Chair of the Joint Committee on Economic Development. Representative Sanchez serves as the legislative appointee to the Commonwealth Health Disparity Council, as Vice Chair of the National Conference of State Legislators Health Committee. Chairman Sanchez earned his Bachelor of Arts degree in Legal Education from the University of Massachusetts and a Master's of Public Administration from the John F. Kennedy School of Government at Harvard University. As a reminder, our webinar today will conclude with a question and answer session. Please note that you will not be identified when you ask a question, nor can other participants see what you have typed. As a reminder, you may participate by clicking on the Q&A button at the bottom right corner of your screen and typing the question. We will also post a PowerPoint presentation on the NCSL website with an audio archive of the webinar. At this point, I will turn the floor over to Dr. Pan. Dr. Pan, please begin.
Well, thank you. Thank you so very much, and it's a pleasure to be here to talk to all of you about determinants of health. This is an issue that I've had a great deal of interest in my medical and public health career, and this presentation actually is a brief summary of a more extensive talk I've given in many venues on determinants of health. I know you got the summary of my background. Basically, I'm a physician and pediatrician, worked actually not only as taught pediatrics, but also development at the University of California, Davis, and been very active in the community in terms of trying to address determinants of health, and been recognized for that before I entered the world of politics. What I wanted to start off with is a slide that actually describes the, one slide ahead there, just sort of to look at some data about causes of death in the United States, because I think it illustrates the issues when it comes to health, where our main targets need to be. As you can see, that the top two are tobacco and poor diet and physical activity, and then following that, alcohol, microbial agents, et cetera. But I think one of the things that this slide particularly reinforces is that health is driven very much by environment and behavior, and that if we're going to try to address our health challenges here in this country and each of our states, that we need to address those particular components. This slide is actually a slide from a book that's called Why Some People Are Healthy and Others Are Not. Back in the mid-90s, there was epidemiologists came together to look at the data on what actually drives health. And this particular slide, I think, is very illustrative of what we need to try to do to actually improve health, not just about health care. As you can see here, what you see on the top here is first you start off with the genetic endowment of the person, the physical environment in which they live, their social environment. So physical environments, for example, housing, traffic that may be around them. They have fresh fruits and vegetables to eat, things like that. A social environment is are you in an environment where you feel safe and secure, or you're constantly feeling like you're under threat, your safety's being challenged. These all combine to impact, create an individual response, behavioral or biologic. You're exposed to you're stressed and you're exposed to a germ. You can come up with cold, a runny nose, or you can lash out. This individual response then impacts your health and function, and also can create a disease state. Of course, the health and function here then impacts your well-being and your prosperity. And the well-being actually modulates individual response. So, for example, if even though someone who's under the same stressors, if someone has good well-being, that may modulate so that it's not such a big deal, but someone whose well-being is very poor may have a more exaggerated individual response. Now, this dark box here represents sort of where the healthcare system usually resides, where healthcare is usually there to ameliorate disease, which then, of course, can have an impact on other components. But one of the things to keep in mind is that we're going to try to address health. It's not just about this dark box, but, of course, about the larger box over here. The next slide I want is actually from Healthy People 2020. So when I first initially developed this talk during 2010, they were moving toward a determinants of health model. As you can see, you see a very similar model. So this is Healthy People 2020, and again recognize the determinants of health with the physical environment, social environment, individual behavior, biologic and genetics, and of course access to health services all influence health outcomes. And emphasize this particular bullet point where it talks about creating social and physical environments to promote good health for all. So as you can see, we're moving toward a determinants of health model and trying to figure out how do we address health in our country. And that's really where the opportunity is for all of us, since we're looking at not only health reform, but how do we transform our healthcare system to try to address improving health, and particularly also addressing health disparities. One of the things that also I want to point out is epidemiologists have taken a look at what are different components of that, how much influence these different pieces may have actually on health, and so as you can see here, healthcare itself probably explains different studies have shown different numbers, but somewhere between 10-15% of the variants that influence health status. Now, of course, if you've been hit by a car or you come down with cancer, this becomes very important that you have that 10-15% difference in variance. But still, I think what you see here is behavioral patterns is 40%, social circumstances 15%, environmental exposure is 5%. So really, the majority of the opportunity to try to improve health actually is about influencing these areas. Then, of course, genetic predisposition about 30%, and maybe research will let us be able to address some of those in the future, but at least at this point in time, really our big opportunities to improve health are in terms of our social and physical environment. This is a diagram from an IOM report, Institute of Medicine report called Unequal Treatment, talking about the racial health disparities. I just want to touch on this, given our topic on disparities here. And as you can see, this basically this model describes the disparity basically coming from clinical appropriateness and need and patient preferences. The operation of the healthcare system, the legal regulatory climate can often create situations which actually, again, disadvantage minority populations. More disadvantaged communities are more likely to be in areas where the physical and social environments are not as health promoting, and then discrimination, biases, prejudice, stereotyping, and uncertainty as well. And so when we look at health disparities, these two particular components are the ones that need to be addressed to try to close the gap. Now, this slide basically talks about what are the opportunities in terms of health development. So the dark blue line here is the optimal trajectory. So that's sort of the optimal trajectory for a person's health. And then what happens is that risk factors come into play that can put the person at risk where they are off the optimal trajectory, this dotted line. And then if there are protective factors in place that can help ameliorate the risks. So what we want to try to do is look at risk reduction strategies, health promotion strategies to try to keep people along the optimal trajectory for their health. And you can see here, this is health development, this is age and years. So the biggest opportunities for impact, of course, are in the younger years. And in fact, I think there's a growing body of research that shows the importance of intervention in childhood that actually has a big impact then on chronic illness later in adulthood. So people, while you may not necessarily see the impact right away in middle age, that the roots of many chronic illnesses actually are because of risks that took place in childhood and adolescence. This slide talks about transitions to turning points of social emotional development. As a developmental pediatrician, what we know is that there apparently are what we call critical points in development where basically if you're at risk that they have a disordinate impact. So and that there are windows of development that if you are able to protect a child through those windows of development from then they're less risk later on. And I think one example of that is that, for example, we know that if a child is born with cataracts in their eyes, that if you don't remove the cataract before the end of the first year, that actually if you then remove it afterwards, that they'll still remain blind because their brain actually doesn't develop the visual centers necessary to interpret signals from the eyes. So even though the underlying problem was that they were not able to see because of cataract, that if you don't fix it in that critical period of time, you actually don't have the brain development that allows you then to interpret for them to see later on. And that's just one small example, and there's many other examples where you have critical points of development, and that's what these points are referring to. The other thing is, as I touched on earlier, is that we're doing more and more research that shows the impact of the multi-generational life course approach. So again, interventions that take place need to not just be focused on one individual, but also on the family, the neighborhood, the household, the neighborhood, national level as well, because they all have interactions, and in fact, many times the impacts are multifactorial, which means that and cumulative. So that means if we could reduce even a few of the risks, that can have an overall impact over time. This is a model that was developed called the Community Guide from the public health community with support from the Centers for Disease Control. And you'll again see many of the same themes we talked about with the previous diagrams on the models of determinants of health. And so you can see here they have health determinants, equity and social justice, societal resources, and then the physical environment. And here we're talking about intermediate outcomes that then lead to health outcomes, things like neighborhood living conditions, opportunities for learning, developing capacity, or education, community development, employment opportunities, prevailing community norms, customs, and processes. So that ties into issues around social norms, social capital, which we'll touch on a little later. Same with social cohesion, civic engagement, collective efficacy, how empowered people are to change their environment, and then, of course, then health promotion, disease, injury prevention, healthcare. So I want to touch on, we saw that weight and physical activity were one of the big factors influencing mortality. And so what I want to touch on here is that this is a slide just showing the economic costs of overweight, obese, and physical activity in California adults. In 2006 up to 2011, see close to 40 to exceeding $50 billion a year. So certainly a big impact. So besides for health and economically, we need to change it. But what do we need to do to try to influence it? And too often people talk about, well, it's just about personal responsibility. And after all, in the bottom here, and this is from the Institute of Medicine Framework for Understanding Obesity in Children and Youth, but sort of actually explanatory for obesity in general, that, well, we can talk about at the very fundamental base here, where obesity is about how much you eat and how much you exercise, that those are actually influenced by a whole variety of different things in the environment. So here, genetic, psychosocial, personal factors, and we can talk about personal responsibility here, but that's then influenced by what your choices actually are in your home, your school, and community, what kind of social norms there are there, and then this is then influenced by policies that we develop in government. We're in, what happens in education, public health, healthcare, our decisions on land use, Are there going to be parks for people to exercise in that are accessible? Where are the grocery stores, and what kind of foods they have access to? And then finally, social norms and values. Food is something that is not just about consumption of calories, nutrients. It's also it's a social construct. I mean, many of our cultural events are built around food. So think about going to a wedding or a reception. So those social norms then drive behavior as well. As a pediatrician, I know families that they get together regularly around meals, and so there's good things about it. There can be bad things depending on what their cultural habits are about that. So how do we try to influence those in a positive way to promote better health? This is the high-scope Perry Preschool project. Is a very important study that looked at the impact of high-quality preschool, and that's in education, but that actually will have also an important influence on health. But as you can see, the Perry Preschool project showed that having access to high-quality preschool actually impacts their future earnings, the involvement in crime, their ability to graduate high school, and many other impacts as well in significant ways. But then the next slide here, actually, this is some data that shows the impact of education on health for a variety of different types of diseases. And so what just to explain this slide, basically what happens is that this is looking at the difference between those people with more education versus less education. Now, if there was no difference caused by the difference in education, then all of these dots would be right along the zero line. This zero means there's no difference. And basically up here, just the number of educational disparity in potential life years lost per 1,000. So imagine per 1,000 divided by 1,000. Someone with less education, basically on average, will lose about almost 3.5 years in their life from cardiovascular disease, more than someone with a person with cardiovascular disease, higher education. You can see here cancer, infection, lung disease, diabetes, trauma. So education has a huge impact on health and your health outcomes. Robert Putnam is a political scientist who wrote Bowling Alone. I think hopefully more people in this group are familiar with it than I usually in the medical folks I talk to, but the concept of social capital or social networks is something that actually has also been shown to be associated with health outcomes. And in fact, this is a study that looked at self-supported health and trust, so trust being a component of social capital, social networks. And there's actually a very high correlation between people's rating of their health, which has been, and the level of trust they feel. They were looking at this in state-level data. So, and I think you saw in the previous community guide model how important it is to the association between the two of how that is an intermediate factor in terms of driving better health outcomes. Also, I just want to touch on this. This is a diagram of asset-based community development. This concept developed by John McKnight and Jody Pressman, which really taps into the power of social networks. And they drive that. How do you improve community development? You need to engage all the different assets in the community, including the individuals who live in the community. That's the center. The informal associations, like the churches and clubs and group activities that happen in communities, and then as well as the institutions like government and nonprofits and businesses. And then, so bringing all of them together can't just be the institutions, but we need to engage and empower the community associations and individuals who live in the community as assets in terms of trying to change the social norms, impact the social environment in the community. That's one of the ways, that's the mechanism for trying to address health disparities and also promoting more positive health norms in the community. I did want to touch on a couple of topics related more directly to healthcare itself. The medical home concept hopefully is one that's familiar to many of you. The medical home is basically is a physician-led team that provides coordinated, continuous, accessible care. A research study that was done in, actually not a research study, a review of the literature on the medical home showed that by Barbara Starfield, who's an eminent health service researcher, showed that international and within-nation studies indicate that a relationship with a medical home is associated with better health on both the individual and population levels, with lower overall costs of care, with reduction in disparities in health between socially disadvantaged subpopulations and socially advantaged populations. So while we're not going to go into detail about all the principles of medical home, I think that's that we need to be looking at closely and figuring out how we can implement medical homes in our health policies to try to achieve these aims. I also want to touch on the chronic care model because chronic disease is certainly one of the things that is much different about health now than it was, let's say, 120 years ago. Because of the success of our healthcare system, we now have more people with chronic diseases. In fact, probably over half of all Americans have at least one chronic illness that they're living with. And this is a model that's built to improve the quality of chronic care. And what you see here is that within the healthcare system, information systems, decision support, et cetera, but also how important it is that we have appropriate community resources and policies to help support informed and active patients and the practice team. So as we're looking at how do we improve health, we can't just look at the healthcare system, but we need to look at overall our larger policies around how we're trying to promote health in communities through things like land use decisions, through our taxing policies, through many other activities as well, and that's how we get the kind of improved outcomes that we're seeking. So this is a sort of a rapid, high-level discussion about concepts and principles associated with determinants of health. So what I want to do now is I'll pass it on to Representative Sanchez, and be happy to also entertain any questions later on when we get to the Q&A session. So again,
thank you very much, Doctor. And it's a pleasure to be on with all of you today to talk about the Massachusetts experience in disparities. I'd like to thank NCSL for bringing us all together today to talk about it, and let me jump right into it. So in the outline, I lay out exactly how we're going to go about it. We're going to look at history. We're going to look at the framework that we put out, how we look at social determinants of health and public policy, and some of our efforts, and then continuing efforts to eliminate disparities, and then the next steps. So let's jump right into history of disparities reduction in Massachusetts, and you see the timeline. Massachusetts legislative leaders have been examining health disparities for almost a decade. In 2004, we held an oversight hearing on disparities and several individual hearings for disparities issues in specific populations. These hearings brought enough attention to the issue that a commission was established to further examine disparities, and which would release a comprehensive report in 2007 showing the need for statewide collective effort to reduce disparities. In 2005, Boston created its own blueprint for disparities reduction, while at the same time, Massachusetts General Hospital, through an initiative led by Dr. Joseph Betancourt of the Disparity Solution Center, established the first hospital-based center for disparities reduction. In 2006, our landmark universal coverage law was passed, and that legislation also established a Health Disparities Council, which bringing together government officials and representatives of the healthcare industry. The council later released a framework cross-cutting many healthcare and policy areas influencing disparities, and this framework became a model for the state. And then in 2008, we created the state of Massachusetts created a council to study not only healthcare costs, but how those costs affect quality. The council was charged to ensure improvements in quality and cost, and also reduced racial and ethnic health disparities. That same year, an Office of Health Equity was created, and this office oversees and encourages government collaboration across varying departments to improve health status and reduce disparities. Over time, we've learned that statewide disparities reduction cannot happen when isolated initiatives drive the effort. Instead, disparities occur because of multiple individual, community, institutional, and policy level factors, as we saw from Dr. Pan's presentation in one of the slides as well. In Massachusetts, we know that a Hispanic adult living in an isolated or urban area suffering from diabetes and high blood pressure did not create the problem alone. Available food options, housing quality, modes of transportation, educational facilities, government intervention, and individual choices play equally important roles. Health disparities result from the dependency of health status on social determinants. Therefore, we can't expect to make an impact unless our policies address these determinants. So I'm going to go down the list of the social determinants of health, some of the initiatives that we've worked on here in the Commonwealth, along with some facts. So we'll start off with housing. In the area of housing, I championed and secured a specific pediatric asthma bundle payment pilot in our FY 2011 budget. The idea was that Mass Health, our state Medicaid program, would allow for bundle payments and reimbursement of services not traditionally covered, such as in-home assessments, in-home mediation. That means they would be able to pay for vacuums or mattress covers and other things, and also it looked for improved communication with the provider. As conditions better managed, not only cheaper, but improves quality of life for previously suffering children, and in a pilot showed promising results. In phase one of the project, 80% of the enrollees were African American. The 46 people reporting Hispanic ethnicity that were part of the pilot. Significant reduction in ER visits related to asthma and in urgent care use and use of rescue medication. All of these points of better management of conditions. While early results are not stratified by race and ethnicity, the pilot group is mostly made up of racial and ethnic minorities. Also recognize the environment's influence over health. Boston has created a Breathe Easy initiative, which allows medical professionals to refer asthma patients for a home inspection. Home inspection identifies asthma triggers in home that can be corrected and alleviate patient symptoms. Boston has also been and is a smoke-free housing initiative to raise awareness on the dangers of secondhand smoke, and works to designate more housing smoke-free in Boston, which is advertised on the Smoke-Free Homes Registry. So again, some ideas around how to address the determinants of health in housing. In transportation, we've established a Healthy Transportation Compact, and that was part of our Massachusetts Transportation Reform Initiative here in the legislature with the governor. It encourages interagency collaboration on transportation decisions, better addressing public health goals, and promoting healthy communities. Short-term wins of the compact include the bike share program back in 2011, and the Massachusetts Bay Transportation Authority, our Metro Transportation Agency, collaborated with Walk Boston to encourage walking routes between stations. We also expanded our Massachusetts Safe Routes to School initiative, which serves over 124 communities. That's 124 out of 351 communities, and provides infrastructure for safe school routes. We also have a program called Mass in Motion, which promotes wellness at the state and community level to prevent overweight and obesity in Massachusetts. And it works with the Healthy Massachusetts Compact, which promotes care access, healthcare quality, contained costs, individual wellness, and healthy communities. The initiative supports regulatory changes, promoting healthy diet and exercise, BMI testing in schools, enhanced workplace wellness programs, and recently the program received $1.7 million in federal funds to combat childhood obesity in the state. Part of our Mass in Motion initiative includes community clinical partnerships also to reduce childhood obesity. It specifically focuses on children from low-income families and communities with high percentage of Hispanic and Black populations. We also know that food access is a big social determinant in health, and we've done a few things relative to this initiative. We passed a comprehensive school nutrition law, which encourages the availability of healthy foods and promotes school wellness. We update school nutritional standards for food and drinks sold in schools. It doesn't apply to foods and drinks that are part of the federal meals program, and the schools provide fresh fruits and vegetables. And we create partnerships between schools and local farmers to sustain local agriculture and ensure food at peak freshness. Kids eat 2/3 of their daily calories in schools, and we have to make sure that they count. School nurses are trained to identify and treat obesity, eating disorders, and type 2 diabetes, and it allows us to nip these conditions in the bud and further encourage overall wellness. We also, through the school nutrition law, establish a food policy council, similar to the goals of the school nutrition law. The Food Policy Council works to increase school purchases of locally produced food, including environment, physical activity, and diet. We looked at it in the bill that I filed. It looks to increase healthy access to foods and gives investment tax credits to qualifying food stores. We track body mass index reporting in schools, and it would require 30 minutes of physical activity daily in schools. Currently, efforts to fight disease focus on health care. This only accounts for around 10% of overall health status. Lifestyle and environmental factors account for over 70% of overall health status. This is where we, as public health champions and legislative leaders, really need to focus. So here in Massachusetts, we're proud because we've taken a statewide approach, and we know that many other states are doing the same. Also, critical steps taken so that healthcare providers, institutions, and communities have tools to identify and correct disparities among their patients and communities, so that both public and private sectors can work together to reduce disparities even further. So thank you so much for offering me the opportunity to come and talk about our experiences here in Massachusetts and some of the ideas that we've had and some of the ideas that we're pushing as we're speaking right now in this environment of cost and quality improvement within our healthcare system. Thank you so much.
Great, thank you. I would like to thank our excellent speakers today, Dr. Pan and Chairman Sanchez. Now we'd like to open the floor to participant questions and answers. As a quick reminder, to ask a question, please click on the Q&A button and type in your question. Please make sure to ask your question to all panelists, and remember that questions will remain anonymous. To start off, this is a question for both panelists, but maybe Chairman Sanchez can start the answer and then we'll move into Dr. Pan's response. With the complexities of disparities, how do you evaluate success of a single program or a single intervention?
I think in Massachusetts, what we've tried to do is that through the council is look at all the different initiatives. And since we're lucky that we have folks from Mass General Hospital that have been quantifying success and finding out what pilots work, like with what we found with Children's Hospital through the bundle payment initiative over at Children's Hospital for pediatric asthma. That's been valuable to us because we were able to find defined improvement in terms of care, in terms of overall outcomes, but also look at the cost as well in terms of finding that reduction in cost because we're not attending children at the emergency room because we have an actual plan on how to work with kids.
Great, Dr. Pan?
Sure. Yeah, actually, it's great to hear Chairman Sanchez talk about Mass General because that's where I did my residency training. Before.
So, in terms of evaluating programs looking at issue disparities, while there are many factors that are involved, as you saw in the presentation here today, one can evaluate the programs, and that what you can do is that what that means is that when you do the evaluation, you want to be sure you have measures to evaluate what's going on in these different areas, but you can still measure the impact of your particular intervention on the your target population and what impact it had on that. I think that what the discussion on disparities indicates is that if we want to have a strong impact on a particular outcome, let's say obesity, then that actually our approach is it is not going to be a single silver bullet. So you can certainly evaluate one particular intervention, but what we need to recognize is that it's probably going to take multiple different interventions in many different domains to have the strongest impact. And so, and we need to recognize that they're all kind of connected together. So you can evaluate individual interventions. You can even evaluate groups of interventions on the outcomes. But I think when we're looking from a policy perspective about what the solution is that it's not going to be identifying that one intervention that's going to suddenly, change the world in terms of reducing obesity or improving, health outcomes, reducing chronic illnesses. It's going to recognize it's actually probably going to be what collection of interventions, and each one's going to have its own separate impact. However, especially when we're looking at this model, it's not just going to be additive; it may actually be multiplicative. So intervention A may only may have a small impact. Intervention B may only have a small impact, but A and B together may be more than just A plus B. And I think that's what we need to recognize as we're developing policy and we're doing interventions. And we're doing, let's say, an A plus B intervention, we may want to do a separate evaluation instead of just assume that all we're going to get is A plus B. Does that make sense?
No, yes, great, thank you. The next question is actually for you, Dr. Given the differential access to care, what are your thoughts about health equity? Do you think that it's a realistic goal?
Oh, I think it is a realistic goal. In terms of trying to achieve health equity, I mean, I think you just saw from Chairman Sanchez some very successful efforts in terms of trying to achieve equity. As we saw in the model that came from the IOM report, there are a lot of different, there are some things we need to try to address that may be inherent in our society that we need to think about what kind of policies when we're talking about disparities because of discrimination or biases and so forth. And then we also have to think about our systems approach, where do our systems basically sometimes promote disparities, not intentionally, but sometimes unintentionally. So, for example, as we're developing our health care systems, and we think about, and we're trying to identify, let's say, primary care providers, but we also have insurer networks that don't reach out sufficiently into ensuring that there are sufficient minority physicians in their network or minority health care providers, then that may make minority patients less likely to access health care, not because they don't have the insurance card, but because they don't have the people they have their existing relationship aren't in the networks. Now they can't see them anymore. So there are a variety of different things we need to think about, and that's why it's so important also when we think about the interventions, not just on the policy level, but it's also reaching into the community. That's sort of why I talked about social norms and social capital piece of it, and the asset-based community development, where it's, there's the policy level, but then also in terms of implementation, we need to reach deep down into the community to be sure that we're developing interventions that make sense to that community.
Great, thank you. The next question is for Chairman Sanchez. Has there been an increase in taxes, et cetera, because of the increased number of individuals being insured? If it wasn't done through increased taxes, how is the state paying for this expansion?
The same way that we did before, and it's a part of the broad conversation that's happening nationally now. When Massachusetts made its decision to move forward in terms of reforming our healthcare system, we all knew that there had to be shared responsibility, and that shared responsibility falls on everyone on everyone. It falls on the individual, it falls on businesses, it falls on government, and we actually redirected. We had a an uncompensated care pool where we redirected funds to help, but redirected those dollars to pay for this, to pay for the prevention, and pay for all the funding of the entire reform initiative that we had here. But not only that, there's commitments directly from the state's capital fund to our healthcare costs as well through our Medicaid dollars and the reimbursement mechanism that we have through Medicaid. So, and also the employers and the responsibilities that employers have in terms of again, the mandate itself. So everyone here in Massachusetts has that responsibility, because here in Massachusetts, as we look at how much we're spending on healthcare, it's unsustainable. Healthcare costs have risen to an unsustainable level. When we were from 2000 to 2010, we've seen increases that are beyond reality. I think we used to spend 20% of our budget, shot up to 30%, and then 10 years later up to 40%, and now we're looking at potential increase in the next decade of up to over 50% of our budget just in pure healthcare costs. So we felt that we needed to get everybody under the umbrella first, and then at the same time figure out how do we deal with the cost issues, and it's what we're working on now. That's what's in conference committee now, where we're looking at how do we make sure that that we promote accountable care organizations, tiering, increasing and improving primary care, allowing for global payment systems and bundled payments where it matters, but allowing that flexibility. And we also now tie the states. An idea that's out there that's pretty prominent is tying the state's healthcare cost growth to the state's gross state product. So a lot's happening here in Massachusetts relative to getting, again, everyone under the umbrella and also containing costs. We never thought that we were going to deal just purely with insuring everyone. We knew that we were going to have to deal with cost and quality at the same time. And in terms of continuing, we know that again, like I said, we're in the middle of that dialogue right now, and there's a lot of people that are looking at what we're doing now in terms of that cost containment bill.
Great, thank you so much. The next question is also directed at Massachusetts. Do you have any idea what accounts for the low rates of enrollment among Hispanics? And I think that they're referring to why the uninsured rate.
Why that 3.9?
Yes.
It's language and isolation. Language isolation, and it's remember, if you look at the number of Hispanics here, it's still, the Hispanics still are a very small minority of the entire state. In terms of the population, I think it's 8% of the overall population. So 8% of the overall 6 million people that live here in the Commonwealth of Massachusetts are Hispanic. So close to 96% is pretty high from when we started. When we started, only 75% of the population was insured. Now 96%, a little over 96% is insured. But again, language and isolation is a really big deal.
Actually, can I just make a comment about that? Because I used to run our Children's Health Initiative here in California and area, and I think when we're talking about more disadvantaged populations, whether immigrants or minority populations, one thing that's really important is to develop that level of trust. And so sometimes, often more mainstream people, there's not that level of trust and understanding that comes from that, and so that makes it more of a challenge. It's not that you can just offer someone an insurance card and everything's fine. There's a lot of follow-up work that has to be done, and so when you're reaching out and certainly to particularly disadvantaged communities and communities that may feel a little under siege sometimes, given the rhetoric and the politics that's around. Sometimes, when you say, well, here I am from, an institution like government, and I'm here to help you, sometimes the response isn't like, whoa, great, well, help me. So I think if we're looking at disparities, we have to look at the systems, we have to look at our outreach into to these communities, and how do we communicate and build that level of trust with the community, so that our interventions would be effective, whether it's increasing access to health care or getting positive health messages out or other types of things.
Great, thank you. This last question is also directed towards you. How do you think we can use health information technology to extend the reaches of physical delivery of services?
Wow. Is that for me? So,
sorry, excuse me.
yeah, sure. I think information technology is something that is probably underutilized in healthcare right now. We're just starting. We are moving toward electronic medical records and so forth. But I think there's a lot more we can do with information technology, especially if we build it on things like the medical home concept. And you saw the chronic care disease model, how actually information technology, we didn't get into detail on that model, but is an important element of that, because a lot of how do we improve our management of illness and also as well as prevention is actually getting information, moving information around, and being sure that patients have and communities have access to good information. So, information, I think telehealth has a tremendous potential that needs to be looked at. But fundamentally, it's still in terms of being effective, in terms of trying to reduce disparities, it's still about building trust with people. So it can't all be done electronically. There has to be face-to-face interaction. People have to have that level of trust they develop with their primary care provider, with public health folks, with other types of folks, and then, but information technology can then facilitate ongoing and communication and also care actually over distances, addressing a lot of our workforce issues with specialty care and other types of areas. So it's certainly something we need to look at us as an opportunity to reduce healthcare costs as well as being able to move information more effectively and reducing duplication in healthcare services.
In Massachusetts, as a part of our cost containment bill, we're a piece that's in the conference committee right now is something relative to health and supporting health information exchanges, so that we can improve interoperability and more information between institutions, as opposed to you go into one hospital, one provider, and them not being able to communicate with each other, and essentially relying on the patient to remember everything that they've gone through in their treatment of care, in their care plan. So again, that interoperability is a really big deal, and it's something that's at the forefront here. We've also used federal funds to motivate and incent providers, small and large, so that they can get up and establish their own their own medical records initiatives in their own practices. It's a monumental effort, but it's something, if we want to modernize and we want to again get everyone under a system, so that we're able to see how we're doing with individuals and make sure that we're focusing on initiatives that make a difference, so that we keep people out of the healthcare system first and foremost.
Great. Thank you again for today's panelists and for all the attendees for your time and participation in today's webinar. Again, a reminder, an archive of this webinar will be available on UNCSL's website in about 2 weeks. We thank you again, and we look forward to seeing you at next month's webinar. Thanks so much.